دكتور سامح إيميل أستاذنا الجميل من الأكاديمية الطبية العسكرية. He will talk about frame AMI trial. وبشكر الدكتور أشرف بيه رضا والدكتور تامر على فكرة الجيم ترايل، فكرة حلوة قوي وي ليرند، بس بستأذنك السنة الجاية طول الوقت شوية. ده تعذيب يا ريس، يعني أنا بجري في السلايدز، يعني بص حضرتك ولا هو جيم ترايل ولا منتال ورك؟ which of which؟ دكتور سامح.
Okay. Thank you very much, Professor Ashraf Reda, and I have a board, and thank you very much, my dear friend, Professor Tamer Mustafa, for inviting me in this challenging session. My trial is the FRAME AMI trial, which compares FFR versus angiography-guided PCI in acute myocardial infarction with multi-vessel disease. This study, the principal investigator is Professor Han, and it's an investigator-initiated open-label trial conducted at 14 sites in Korea. The background is that in patients with acute MI and multi-vessel disease, after treating the infarct-related artery, treating the non-infarct-related artery improves the clinical outcomes. However, the optimal strategy to select targets for non-infarct PCI has not been clarified. So the objective of this was to compare the FFR-guided PCI with angio-guided PCI for the non-infarct-related lesions among patients with AMI and multi-vessel disease, proposing that the FFR-guided is superior to the angio-guided. The inclusion criteria: patients with STEMI or non-STEMI undergoing successful primary or urgent PCI for an infarct-related artery, and they have another artery with more than 50% luminal stenosis, provided that this is a major epicardial artery with a diameter of 2 or more, and they excluded patients with single vessel disease, target lesion in left main, and cardiogenic shock. This was the study design. They randomized the patient after the primary PCI to either FFR-guided revascularization or angio-guided revascularization for lesions more than 50%. For the FFR-guided, those who are less than 0.8, they performed immediate revascularization, while those who are more than 0.8, they deferred the revascularization. While the angio-guided, they performed immediate revascularization for all lesions above 50% stenosis. The primary endpoint was a composite of DAS MI or repeat revascularization, and the secondary endpoints was the components of the primary endpoints individual. The patients were 280 in each group that completed the trial. There is an early termination for the study due to the COVID pandemic, due to unavailability of facilities and lack of personnel. Of course, the baseline of the two groups were equal regarding the age, the gender, and the risk factors. Also, the ejection fraction is almost the same, and the antithrombotic treatment is equal in the two groups. For the infarct-related artery, for the non-infarct-related artery, the FFR-guided only 64% performed the procedure immediately, while 97% in the angio-guided performed it immediately, which was statistically significant. Finally, the non-infarct PCI was almost 60%, while it is 94% in the angio-guided group. These are the results. The primary endpoints were in favor of the FFR-guided strategy, with a highly statistically significant difference after a 4-year follow-up. And the components of the primary endpoint, whether it is cardiac death, myocardial infarction, procedural myocardial infarction, were statistically significant in favor of the FFR-guided PCI. But the study limitations is due to early termination, and that they involved patients with STEMI and non-STEMI with multi-vessel disease. So the conclusion of the FRAME AMI was that among patients with AMI and multi-vessel disease, a strategy of a selective PCI using FFR-guided decision-making was superior to strategy of routine PCI based on angiography diameter stenosis for the treatment of non-infarct-related artery lesions regarding a composite of death, MI, or repeat revascularization. Yet, this trial was not consistent with other previous trials and meta-analysis, as we can appreciate here from this French trial, the Flower MI, which was presented in the EuroPCR 2021 and was published in the New England Medical Journal, with the same study design and the same primary endpoints, but a higher number included in each arm. The conclusion is that the primary outcome was 5.5% in the FFR guided, and it was better in the angio guided, and no significant difference was observed in the secondary outcomes. Also, in a Korean meta-analysis published this year in April, they compared several revascularization strategies, including the FFR guided versus the angio guided, and they concluded that, however, there was no significant difference between angio guided and FFR guided complete revascularization strategies in the risk of MACE and its individual components, including death, cardiac death, MI, and revascularization. And so we can appreciate from these figures in this meta-analysis that the angio-guided complete revascularization has a margin of to be better than the FFR-guided revascularization among the all-cause death, cardiac death, MI, or major adverse cardiac events. So I'll conclude my talk by the statement, the comment of Professor Hen on his trial that the guidelines are unlikely to change solely based on the results of our trial, but in clinical practice, interventional cardiologists may choose FFR-guided decision-making in patients with MI and multi-vessel disease. And thank you.
Thank you, Professor Sameh.